Welcome all. Now we continue with gynecology. The first topic and the very important topic from the examination point of view is a cervical intraepithelial neoplasia. Most frequently, this topic is asked as either as a short note or it may be a part of the full question also. Okay, so what exactly the cervical intraepithelial neoplasia? Not only from theory point of view, but in the practicals, this will come during the discussion. So concepts are very important. So please listen to this talk carefully. So cervical intraepithelial neoplasia is a pre-malignant condition of the cervical squamous epithelium, which is characterized by the dysplastic changes without the breach of the basement membrane. So this is very important. So there are dysplastic changes in the cervical squamous epithelium, but there is no breach of the basement membrane and it's a pre-malignant condition. So these are the things which you should mention when we are talking about the CIN. It represents the continuum from the mild dysplasia to the severe dysplasia to the carcinoma in situ. Okay, so it's a spectrum from mild dysplasia to the carcinoma in situ. Okay, so untreated, if you don't treat the CIN, what is going to happen? It may regress, it may persist, or it may progress to the invasive carcinoma. So this is what is the fate of the CIN, either regression or persistence, or there may be progression to the carcinoma. So if you see the normal epithelium, so this is how the normal epithelium, and here is a basement membrane, and these are the dysplastic cells. Now when this dysplasia is up to the extending less than 1/3, then it is a CIN1. If it is reaching up to 2/3, then it is CIN2. If it is more than 2/3, it is CIN3. If it is a full thickness but without a break, then it is a carcinoma in situ. And when there is a break of the basement membrane, we label this as a cancer. Okay, so this concept you should be able to mention properly either in the discussion or in the writing. You should be able to. So there is an evolution of the nomenclature. Years you may not remember, but certain things, how this nomenclature has changed with respect to the time. In 1910, Rubin proposed the term carcinoma in situ. That is the full thickness involvement. Okay, in 1956, these were the Walters and Regan. They introduced the concept of dysplasia. Okay, in 1967, Richard introduced the concept of CIN. Okay, so then this WHO in 1975 classified it into CIN1, CIN2, CIN3. Okay, and the latest one in 1988, the Bethesda system. Now we use the terms such as LSIL and HSIL. Okay, so these are the terms which are used now. Low-grade squamous intraepithelial neoplasia and high-grade squamous intraepithelial neoplasia. So these are the two terms, and as a specialist, you should know how the evolution of the nomenclature has happened and what is the correlation of this. Okay, so the next table is going to be very, very important. See, initially the terminology was mild dysplasia, then came the CIN, and the latest one is the LCIL and HCIL. Okay, so when we talk about mild dysplasia or CIN1, generally the thickness of the dysplasia is involving the lower 1/3. Okay, and as per the newer system, we call it as a LCIL. Okay, while moderate dysplasia and CIN2, when the dysplastic changes are restricted to the lower 2/3 mainly. Okay, and as per the Bethesda system, this is HCIL. The severe dysplasia, when the changes are more than 2/3 of the thickness, while CIN3 is almost full thickness, and carcinoma in C2 is the entire thickness is involved, but there is no break of the basement membrane. Okay, so mild dysplasia and CIN will correspond to lower 1/3, moderate and CIN2 will correspond to the lower 2/3, while severe dysplasia, carcinoma in situ is concerned about the more than 2/3. Carcinoma in situ is involvement of the complete involvement without the breakage of the uh, basement membrane, and out of which, as per the newer system, only the mild dysplasia or CIN1 comes under the LCIL, while the rest are HCIL. So this correlation is very, very important. This you should mention either in the discussion or in the theory. You can draw this table also. Okay. Now the concept of transformation zone, this can be asked as a short note. Okay, so transition zone is the area between the original squamocolumnar junction and the new squamocolumnar junction. Okay, so where the columnar epithelium undergoes the squamous metaplasia in this transformation zone, where the columnar epithelium will undergo the squamous metaplasia. So we know well that this is the cervix, it is lined by the columnar epithelium, and this is the ectocervix. So this is the endocervix and this is the ectocervix. Okay, so the endocervix is lined by the columnar epithelium, while the ectocervix is lined by the squamous type of epithelium. So when you see, so this inner aspect will be the columnar epithelium. This outer aspect will be the squamous epithelium. So at the junction where the columnar epithelium meets the squamous epithelium, there is a squamocolumnar junction. But this squamocolumnar junction is a static. It's a dynamic. It's not at. It's not a static. It's a dynamic. It's not at one place. It is under the influence of progesterone. What happens? This squamocolumnar junction or this moves outwards, while in the postmenopausal phase it will regress inside. Okay, so what happens during the puberty or the reproductive age group? There is this columnar epithelium, because this squamocolumnar junction has migrated here. There will be columnar epithelium. This columnar epithelium will be exposed to the vaginal acidity, and with this environment, this columnar epithelium will undergo metaplasia, and it will form the squamous type of epithelium. So original squamous was here, then this was initially it was a columnar which has become the squamous, and it forms the new squamocolumnar junction, while here was your original squamocolumnar junction, and here it became the new squamocolumnar junction. Okay, so here the same thing. Okay, so you see that the new squamocolumnar junction is formed here. Okay, so this transition zone where the cells are metaplastic. Okay, there is a metaplasia. These are the cells which are prone for the infection with the HPV, and this is what is the main etiopathogenesis for the carcinoma of cervix. Okay, so 95% of the cervical cancers arise in this squamocolumnar junction. Okay, so this squamocolumnar junction or this transformation zone, I mean to say, so this squamocolumnar junction is the meeting of the endocervical columnar epithelium and the ectocervical squamous epithelium. That is the junction. Okay, that is the squamocolumnar junction. Endocervical columnar epithelium meets the ectocervical squamous epithelium. The characteristic of this is that it is a dynamic structure. It changes with the puberty, pregnancy, and the menopause. Okay, so what is the pathogenesis? So this squamocolumnar junction, because of the acidity of the vagina and the acidic pH, there's a squamous metaplasia. Okay, and these are the immature unstable cells that makes this HPV virus to have the persistence. Okay, so once the HPV, because normally HPV infection there is a clearance, but if in these immature cells it favors the persistence of the HPV infection, that will lead to the integration of the HPV DNA into the cells, and you will get two oncoproteins from the HPV, and these are the two villains which you should know. E6 and E7 are the oncoproteins, which are the HPV oncoproteins. E6 and E7, which are the oncoproteins, that will lead to the inactivation of the P53 and the retinoblastoma gene. So these are the safety mechanisms. We know P53 is important for DNA repair. Okay, and even RB gene is important for the safety mechanism, but these are inactivated, and that leads to the cell immortalization, and that leads to the CIN, leading to the carcinoma in situ and leading to invasive carcinoma. So this pathophysiology you should be able to describe. Now let's talk about the HPV pathogenesis. So what happens? So how does this virus enters? So the transmission is a sexual transmission, and it is the microtrauma during the intercourse. The virus will infect the basal cells of these transformations. Okay, so this pathogenesis also you can describe when you are asked about the short note of the transformation zone. So virus entry is through the sexual transmission. There is a microtrauma during the intercourse. The virus infects the basal cells of the transformation zone. And what is the molecular event which is happening once there is an infection? So the high risk HPV, once we know that there are high risk and low risk, there is a DNA integration and there are two villain, E6 and E7 protein. This E6 protein will destroy the P53 and E7 protein will inhibit the RB gene. Okay, so that will lead to the loss of cell cycle control, leading to the uncontrolled proliferation, leading to the CIN and leading to the cancer. So which are the high risk HPV and which are the low risk HPV? Again, a very important question. So high risk HPV are 16, 18, 31, 33, 35, 45, and 56. Okay, 16, 18, 31, 33, 35, 45, and 56. While low risk are 6, 11, 42, 43. Okay. So as far as high risk are concerned, these two you have to remember 16 and 80. HPV 16 and 18, they are responsible around more than 70% cases of the cancer. Okay. So risk factor for the carcinoma of cervix, the risk factors, the sexual factors such as early onset of the sexual activity, less than 16 years, multiple sexual partners, multiple pregnancies, high parity. Viral infection, well established is a HPV infection, and other associations are HIV, chlamydia. These are other associations. Then lifestyle related factors such as smoking, oral contraceptive use, etc. And others are low socioeconomic status, immunosuppression, husband with previous wife having the cervical cancer. These are other epidemiological association with the carcinoma of cervix. And this you should know, and you should mention about the natural history of the CIN. We know that CIN, there is a CIN 1, CIN 2, and CIN 3. But the most important thing, if you see the CIN1 regression rate is high, 60% will regress, 30% will persist, and only 10% is the progression rate. So if the infection with HPV or if there is a CIN1 change, if you see in the cells, then there is only 10% chance for the progression. But if it is a CIN2, there is a regression less, that is 40%. Persistence is seen in 35%, and progression to the carcinoma or CIN3 and carcinoma in situ and carcinoma cervix is seen in 20% of cases. While if it is a CIN3 pathology, then only 30% is the regression, while 50% chance of persistence. And once there is a persistence, there is a chance of progression. Okay, so more the persistence, more are the chances of progression. So if CIN1 is there, less chance, high chance of regression, less chance of progression, and average chance of persistence. This persistence chance also increases with the grade of the CIN, and from persistence to the progression will also increase as your CIN1 becomes CIN2 and CIN3. Okay, so this progression timeline also you should be able to mention and clarify in the viva. So if there is a normal cervix and suppose a lady develops infection by around 25 in a young reproductive age group, and it is a CIN1 pathology, then this CIN1 will progress to CIN2 to CIN3. But from CIN1, the chance of progression is only 10%. If it is 2, then it will be 20% chance of progression, but the persistent chances will also increase. Okay, and that is why the progression chances will also increase. So the lady who is developing the infection by around 25 to 30 years, from CIN1 to progress it to CIN3 or CIS, it will take at least 10 years. By that time, she will be 30 to 35. Still, there is no cancer. Changes are between CIN1 to CIN3 only. And this is what is the most important thing, which is making this cancer curable and possible for the screening. So these are the concepts which are expected from the candidate. Okay, you should be able to explain well, because this is a long window during which you can pick up these changes and treat the lady. Okay, and from here onwards, then it will progress to the invasive carcinoma over a period of next 5 to 10 years. Okay, so how will you diagnose CIN? The tests are one, Papinicola smear you can do. Second, by detecting the HPV, because HPV will lead to this type of changes. So you screen for the HPV itself. Then visual inspection of the acetic acid with the acetic acid, colposcopy, and cervical biopsy. Okay, so these are the things which you should be describing after that. So what is the HPV triage strategy? First, you take the smear, or if you see that smear is abnormal, or if you see atypical squamous cells, then you go for HPV DNA test. If the HPV DNA is positive, then go for colposcopy and take the biopsy. Okay. If it is abnormal and you carry out HPV test, HPV DNA, and if it is negative, then you will keep her under surveillance with the cytology only. Okay. Then you can repeat the smear after 1 year. Okay. So that is how you should go ahead. Then colposcopy can be asked as a short note. So colposcopy is the examination of the cervix under 6 to 16 magnification after application of 5% acetic acid. What is the importance of the colposcopy? First, it will identify the abnormal area. It will help us in taking the biopsy, and though it will help us, it is not a substitute for cytology. Okay, colposcopy is not a substitute for cytology. Cytology screening will continue. When there is abnormal pap smear, then you can go ahead further with the colposcopy. Okay, so indications for the colposcopy are abnormal pap, suspicious cervix, postcoital bleeding, and if there is a HPV positive test. Okay, so certain terminology you should know. When will you say that the colposcopy is satisfactory? To say the colposcopy is satisfactory, you should be able to visualize the squamocolumnar junction. Okay, so you should be able to see the entire squamocolumnar junction in the 360 degree. Okay, in the 360 degree. Okay, then entire transformation zone. Now this transformation zone is a area. So it has got a length from anterior to posterior, and it will be in a 360 degree. So that zone you should be able to see entirely. Okay, and if there is any lesion, you should see the lesion complete. Suppose there is a small ulcer, you should be able to see all the edges of the ulcer. Then we say that the colposcopy is satisfactory. If the part of the lesion is inside, not visible, then this is not a satisfactory colposcopy. So to say that your colposcopy is satisfactory, you should be able to visualize the entire squamocolumnar junction, entire transformation zone should be visualized, and entire lesion should be visualized. Then what are the abnormal colposcopic findings? They are divided into two: minor changes and the major changes. Minor changes are aceto-white epithelium, fine punctations, and the fine mosaic pattern. While major changes are the dense aceto-white areas, coarse punctations, and the coarse mosaic. While fine punctation and fine mosaic are the minor changes. Okay. Then what are the findings which are suggestive of invasive cancer? The findings suggestive of invasive cancer are atypical vessels, okay, irregular branching vessels, ulceration, and friability. These are the changes which may suggest the invasive cancer. However, biopsy is going to be must. Okay, so in vivas they can ask you, why does the aceto-white epithelium appear white? Okay, because you apply the 5% acetic acid, there is a coagulation of the intracellular proteins of the dysplastic cells that produces white discoloration. Okay, so there is a coagulation of the intracellular protein of dysplastic cells that leads to the white discoloration. Okay, so next what you can do is a biopsy. Okay, when you have the colposcopy available, you take the biopsy under the guidance of the colposcope, that is a directed biopsy. Okay, when colposcopy is not available, you can use a Schiller's iodine test. You can do the punch biopsy from the abnormal area, or ring biopsy you can do, or endocervical curettage you can do. Okay, the indications of the diagnostic cone biopsy. What are the indications for the diagnostic cone biopsy? When colposcopy is available and the colposcopy is unsatisfactory, you cannot see the squamocolumnar junction. If there is a positive endocervical curettage, then microinvasion is suspected. Cytology and biopsy is not correlating, and if it is a high grade CGIN, okay, glandular pathology is there, then you go for cone biopsy. Okay, so these are the indications for the diagnostic cone biopsy. If colposcopy is not available, then persistence of the abnormal smear, carcinoma in situ is your diagnosis, or cytology and biopsy discrepancy is there. In that particular case, you can go for diagnostic cone biopsy. Then what is the treatment for the CIN? Treatment will depend upon the age of the patient, desire for the fertility, grade of the CIN, and availability of the follow-up. Okay. So options may be conservative, it may be ablative, it may be excisional, or there may be definitive treatment also. So conservative, just keep under observation. Then ablative, such as cryotherapy, cold coagulation, electrodiathermy, and laser vaporization. These are the options which are available. And excisional are the leads, that is large loop excision of transformation zone, or LEEP. Okay. Then cone biopsy, and definitive treatment is a hysterectomy. So if you see the grade of the CIN, so CIN1 can be kept under observation and continue the surveillance with the PAP and HPV. That can be observation, CIN1. CIN2 generally go for leads, and CIN3 biopsy definitely you will take to rule out the invasion, and excision you can go ahead, leads or the cone biopsy you will require for CIN3. Okay. Then ablasive methods, indication for the ablasive method, for ablation to be done, there are very specific indication. Most important is that you should be able to see the entire lesion. Okay, if the lesion is not visible completely, then you cannot use the ablasive method. You do not know what is the further extent inside. Okay, so lesion should be visible, then squamocolumnar junction should be visible, there should be no invasion on the biopsy, no glandular disease, cytology, colposcopy, and biopsy should match. Okay, so these are the indications for, or prerequisites I would like to say, for ablasive, because you are going to go for conservative management by doing ablasive methods. So entire squamocolumnar junction should be visible, entire lesion should be visible, there should not be any invasion. Then it should not be a glandular disease. So CGIN is not a choice for the ablation. Okay. Then cytology and colposcopy and biopsy should match. Contraindications: when you suspect the invasion, squamocolumnar junction is not visible, or if it is a glandular lesion, or there is a discordant or discrepancy in the cytology colposcopy. Okay, then you will not go ahead with the ablation method. So there are different ablation methods such as cryotherapy, cold coagulation, electrodiathermy, and laser vaporization. Then what is the depth in each method? So cryotherapy will destroy around 5 millimeter. The technique is a freeze, thaw, freeze technique. Coil coagulation, the depth is around 4 millimeter and 100 to 120 degrees centigrade. No anesthesia is required. It is minus temperature actually. Then electrodiathermy 8 to 10 millimeter and requires general anesthesia, and laser vaporization 7 millimeters. It is best for vaginal extension. Okay, laser vaporization. If there is a vaginal extension, you can go for laser vaporization. Okay. Then next is a LEEPS. Okay, large loop excision of the transformation zone. Okay, so large loop excision of the transformation zone using thin stainless steel wire loop with blended cutting and coagulation current. So what we use is a loop, that is a thin stainless steel wire loop with blended cutting and coagulation current. Advantage is that it is a OPD procedure done under local anesthesia. It is quick. There is a minimal blood loss. Histopathology is available and less complications than the cone biopsy. Okay, so this is most important. Cone biopsy is more blood loss is there. Okay, and this is a OPD procedure. Well, cone biopsy, you will require anesthesia, theater. Okay, the depth of invasion is 10 millimeter or more with the leads. Then follow up, you have to do cytology at 6 months, repeat at 12 months, and then every 3 years. Okay, so this follow-up is must. The patient should be, so once you have done the leads, it doesn't mean that the patient is should not come for the follow-up. The treatment is over. No, you will keep the patient under follow-up, cytology at 6 months and 12 months, and then every 3 years. Okay, then what are the complications of leads? Bleeding, infection, cervical stenosis, cervical incompetence. This is less common than the cone biopsy. Okay, the last is a hysterectomy. The indications will be CIN with some other gynecological pathology like fibroid, prolapse, PID, etc. Or if there is a vaginal extension, persistent dyskaryosis, high-grade CGIN, especially in elderly patient, CIN3 with poor follow-up, cancer phobia. These are the indications for the hysterectomy. So from examination point of view, certain things about the transformation zone which you should remember. Transformation zone is the site where almost all CIN develop. Colposcopy identifies the lesion. Biopsy will confirm the diagnosis. Okay, colposcopy will identify the lesion, but biopsy will confirm the lesion. Next, LEEDS is the treatment of choice for most of the CIN2, CIN3 lesions. Okay, ablative methods destroy the tissue and do not provide histology, whereas excisional methods such as LEEDS or cone biopsy will provide a specimen for histopathological examination. So this is the most important. That is why there are prerequisites when you are selecting the ablative methods. You have to be very sure that you are able to see the lesion completely. You are able to see the Squamocolumnar Junction transformation zone completely, and there is a no discrepancy in the cytology, biopsy, colposcopy. There is no discrepancy. All are matching. Then only you go for ablative method. And advantage with excisional method is that they are providing you the tissue. Okay, so that finishes the today's topic of CIN. Thank you.